I work for Channel 4. I specialize in politics, and I've had an opportunity to really extensively cover the Medicaid coverage gap in our state. I've met people from all walks of life, and it's really a very complex issue, one with varying point of views. We're going to get into some of that today, but as opposed to focusing more on what hasn't happened to this point, we really in this panel are going to focus on moving forward, as the title suggests, crossing the finish line. So where do we find common ground? And how do we move forward in meeting the needs of those that fall into the coverage gap here in the state of Utah? So you've already been introduced to the panel members, and I'd like to go ahead and, oh, I'm probably doing that, aren't I? Can I put this down? I'm not a musician. All right, so we're going to go ahead and start with Grant. Grant, I'd like you to talk to us a little bit about how you found yourself in this situation in the coverage gap and what the challenges you face on a daily basis are.
First of all, I'd like to start out by thanking all those that are here. It's a reflection of your character. I believe that you care. One of the things that I have found as I have experienced these difficulties, there's a lot of caring people in the world. Sometimes that even includes caring politicians. And I would congratulate Speaker Hughes for being brave enough to be here. I've spoken with him before, so I hope he forgives me if I get rough. But I'm not afraid of his character because I know how tough and good he is. Perhaps we could also invent one more term, and that would be a temporary game of four. We've been tasked with the ideas that we should discuss to move forward. And I think we'll leave some of the things in the past, and we'll do that. To briefly tell you about me and my story, we could be here for 6 hours, and maybe someday I'll write a book about it and make some money, and that'll solve my problem. But quite frankly, that's not a very practical solution. And it isn't a solution for most Utahns. I believe in insurance is. And so what happened with me is I underwent a medical procedure that injured me. And I don't like to even bring that up sometimes because I have friends that are doctors and I don't want to bring up that. And so I don't often like my story to focus on those matters. But what I found myself in a situation where life almost even overnight changed for me. I was moving along with some of the various challenges of life and being successful in some areas and not successful in others, but I promise you I was making pretty good income. But I ended up with a very complicated medical problem. And this was prior to even the Affordable Care Act. And I ended up with a nasty set of pre-existing conditions. Back when an insurance company would just simply close their door if you were someone who thought it would be expensive. Now, I've got friends who are insurance agents. I don't necessarily want to badmouth them either. But that's the way insurance kind of works. It's a risk management thing. And we've probably spent the whole morning talking about that. But I found myself with a tough medical problem, and I still got it. I'll go home and spend 2 days on the toilet. And I know that's TMI. Yeah, it really is. I'll go home and I'll mess with sores. I put them right up there with Joe's. They're nasty. They hurt. They may go someday. They may go septic, and I may not be here. They're fungal in nature. They're not bacterial. So if you give me antibiotics, you'll send me to the emergency room for sure, and then I'll be talking to Dr. She is out for a while. The answer that I thought that I could find was some of the changes that are now happening in America, and the very fact that there are smarter ways to do things. And so my story chronicles the difficulty of having a difficult medical problem in the world of the American healthcare system. I participated in a clinical trial, a cancer clinical trial for a sister with breast cancer. Now you tell me, was I off doing something awful or just trying to help somebody? And then I found myself in a situation where anger management was one of my issues, where I had to keep trying to go. And so I, on a daily basis, I'm trying to get better. It's as simple as that. Now, when I walked in the door to the Share My Story program of Riley Curtis, I felt like I walked into the room of angels. And yet I'm still working with the problem. So I don't know how much background to give you, other than to say that there's a lot of smart people in this room. And we ought to get together, forget the politics some days. In fact, send some people away that have us completely rule our lives with that. And we ought to get down to the business of making some solutions, and not just for me. There may even be found some personal solutions for me, but that nonetheless will leave people behind. And what we need to be working for here is not necessarily even a solution for me, but a solution for many. And I'm not sure how much more you want to let me talk. But that's probably enough.
Yeah, thank you for that. We'll move on from there. Speaker Hughes and Senator Shivazawa, I'd like you to talk a little bit about people you've met who find themselves in the same situation as Grant, and how does that weigh on your mind as this discussion moves forward?
Thank you, Glenn. I appreciate being here. I'm used to it.
Yeah.
I really am. I'm used to it.
I don't worry about that at all.
I was born for the storm, okay? I can handle it. No, these are tough issues, and I came purposely because sometimes we have to talk about things that are uncomfortable. We have to hope to understand each other and have a broader perspective and get to those solutions where we can work together and get something that will really move the needle and improve our human condition, and particularly in healthcare and the gap that we have. So I've had, thanks to Representative Ward, who's also a physician, we have in the House 4 practicing physicians, and their perspective, and it would be interesting if you met them. They're not all cut from the same philosophical cloth when we talk about this particular issue. They vary, the 4 physicians do, in terms of the approach. But Dr. Ward, Representative Ward, shared an opportunity with me to meet with Grant and other people that find themselves in the coverage gap. And being able to talk to each other, not in a committee hearing, and not maybe in it was in my office, so I guess it was still political, it's at the Capitol, but it maybe in a more informal setting, certainly allowed me to appreciate the trials and the circumstances that are not some of the ones maybe you hear nationally, or some of the talk about healthcare or free healthcare. These are all very complicated issues, and people find themselves without income or without the needed healthcare for various reasons. Grant, when I saw him when I arrived today, I think about Grant a lot. I think about his circumstances and how he was doing what any big brother or any brother would want to do, and that is be there for his sister, and how that has left him in your health and what happened there. I would like to think that if we had a traditional Medicaid program there for the disabled, that this is something that Grant should absolutely have qualified for a long time ago. And so even as we talk about this coverage gap, I think there are other issues that I'm seeing as I learn about people's circumstances that also spread into other areas of the healthcare that we already are supposed to be providing, and maybe falling short in doing that. The human part, if there's any takeaway here, and we might not agree on how we journey on this path, I just want you to know the decisions that we're making in the legislature, and I can speak as we meet as a House, these are not born from callousness, and it's not born from an ignorance of people's circumstances. There's some tough decisions being made in that we want to make sure what we do, we can do. And we don't want to be in a situation where we are making promises and creating expectations that we worry we would fail and not be able to provide. And we think about those things. And I can tell you that when you consider the human toll, these policy decisions are heart-wrenching, and they're hard, and I just want you to know these are done with a depth of appreciation and concern that you want from your legislator. And I know that's the case in the Senate as well. So I don't do anything succinct. I know I'm supposed to hurry here. I'm sorry. To answer your question, Glenn, the people I've met since we have really worked on this issue and the perspectives that have been shared have given invaluable context to this issue for us, for me and most of my colleagues.
Do you have anything you'd like to add, Senator?
Well, first of all, thank you for being here. Thank you for being knowledgeable about the basic medical crisis we have here in the state of Utah. Now, we recognize that medical insurance is expensive, it's complex, but one thing we can agree on, the patients do get better health care, they have better outcomes if they have health insurance than if they don't. Now, my experience with people who fall in the coverage gap or who don't fall in the coverage gap is, last night, this morning at 1 a.m., I would tell you about 1/4 of my patients at St. Mark's were uninsured. And they come to that ER in the middle of the night because either A, they can't get into their doctor's office, or they have no doctor because they're working during the daytime, or they can't get in anywhere in the middle of the night because they don't go to urgent cares because they have no insurance, and therefore the insurance, with that lack of insurance, they get sent to the single most expensive place in this state, and that's the ER. And we take care of them. And we hope we do a good job, and we stabilize them. And then we send them out. So my experience with them is on a daily or a nightly basis. And so I have an appreciation, perhaps, of this particular coverage gap from that perspective. And I appreciate you understanding a bit of this, whether it's in person or vicariously, and giving a voice to those people who don't have a voice, and speaking up for those who can't speak for themselves.
Let's talk a little bit about the numbers of the coverage gap, and we'll pull you in for this one, Nate. Estimates vary as to how many people within the state of Utah fall into the gap, depending on the study that you look at. There's a commonly used number of right around 54,000 people. Estimates go as high as upwards of 87 to 89,000 people. On the state level, what are we looking at number-wise? How many people fall into this gap?
Sure. Excuse me. Sure. And at risk of hopefully not insulting an audience as sophisticated as yourself, I'll just kind of reiterate what the coverage gap is. It's a demographic of people, Utah adults ages 19 to 64, who don't qualify for Medicaid under its current design, and who, by virtue of being in poverty, don't qualify for premium subsidies or cost-sharing reductions on the exchange. The estimates that we've used for the coverage gap population, for many of the actuarial modeling that we've done for both Healthy Utah, Utah Access Plus, I think virtually any of the proposals that have been circulated, it was about 77,000 Utahns. More recently, the Department of Health published some numbers from their behavioral risk factor surveillance survey that suggested that the number was around 62 to 65,000 Utah adults. Other public use data sources would range from 60,000 to 70,000. So I think the Department of Health's figure sort of straddles what's publicly available.
And how many of those do have access to insurance through an employer, but just can't afford it, and that's why they're in the gap?
Interesting question. I don't have that data piece in front of me. However, these are individuals who are in poverty. I think about 60% of that demographic has worked either full or part-time, and been employed in some capacity during the same year in which they were uninsured, but either didn't have access to insurance through their employer, couldn't afford it, or because of temporary durations in unemployment or part-time employment, or being in larger family sizes. A household of 4, I think the federal poverty level is less than 25,000, which is certainly more than the age of working full-time. And so all of these different factors produce a situation where these individuals do not have access to the same sorts of premium subsidies and cost-sharing reductions that Utahns who are better off have access to, and who also do not have access to traditionally.
Okay. Speaker Hughes and Senator She was out. Let's talk a little bit about the financial portion of this, because that's a big part of this discussion. You hear the governor talk about when he's pitching his Healthy Utah plan, for example. We're giving money to Washington anyway. We should be getting some of it back. A lot of the House argument is we need to find a way to cover our portion of this. So it can be a little confusing for people looking in. Well, what's going on here? One says we are going to get money back. The other says we need to find a way to pay for that. So let's delve into that if we can.
I'll always give Senator Shoes on the last word, so he can clear up whatever it is I say that he doesn't like. It's a great question. Now we're going to walk right into the problem we have with this issue, okay? We're going to talk math on a very emotional issue, okay? And this is where I feel that in my journey in this policy decision and how we do this, when we're talking math, people want to talk about grant, and appropriately so. And there becomes a disconnect. And it sounds like people are more worried about numbers than they are about people. But I have to tell you that before I jump into the math, I want you to know you've got to get the math right on the state side. We have to balance the budget. We have to be able to pay for the things that we budget for. And we're not the U.S. government where that can deficit spend. The Congress can have an appetite. It never has to match what arrives by way of tax revenue. The states, all 50 states, do not have that option. If we commit to public education, health and human services a number, and the tax revenues don't arrive, we have to go into special session and cut. And we feel the human impact of those cuts when we get it wrong. So these numbers are incredibly important. But again, I say this ahead of time so that your takeaway is not that we're just worried about numbers over here and not about people. Here's the challenge. Even in our health and human services budget, or if you look at traditional Medicaid, which are for the permanently disabled and for children, we budget to a number. We budget an amount that our state will dedicate, and it correlates with the rest of the state budget. What we don't do is budget to a percentage of a future cost. So one of the big challenges that we had budget-wise in trying to commit the state to the expansion was 10% of an ultimate cost, and the state doesn't pay it right away. One of the things that happens is in this case, for ACA, Medicaid expansion, the federal government will pay all of it now. I will just tell you that if I want to be popular, if there's a notion out there that it is more popular to say no to Medicaid expansion than it is popular to say yes, it is not popular to say no to this program on any front. Even with conservatives, this is not ranking as one of those bellwether issues for those that you would categorize as they don't like the Obama administration, they're conservative. This isn't a clarion call, and lawmakers are not being forced into a no vote on this. With the amount of important things we would be accomplishing if we said yes, it is much more popular. And if your weather vane is to be popular, yes is the answer for this policy debate. When the federal government pays all of the amount of the expansion at the onset for the first few years, the consequences of the wrong decision will not be felt anytime soon. The state of Utah will be obligated for 10% of an unknown amount in the year. It starts in 2017 and then it steps up, and the full amount that we'd be responsible for is in 2020. Here's the challenge. We've had actuarial studies done to say, look, we don't know what the number is. What we've got to do is the best job we know how to know what we think that number will be. So we hire actuarials to do the studies and to look and to see what that number will be. That number came out to be $80 million of general fund ongoing. Once it hits its take-up rate and it's there by 2020, the amount will be $80 million a year, ongoing. The challenge is we saw in the data, Glenn, from other states that had already expanded Medicaid, and we looked at what they were projecting, their ultimate cost, and what they would be obligated as a state to pay. Their enrollment was far beyond and a lot higher than what they were predicting. And so the take-up rates and the people that are enrolling are in excess. You were seeing in the first couple of years more people enrolling than what they thought would be the enrollment amount in the year 2020. And those numbers continue to climb. Well, that brings pause. Not because we don't care, not because we don't think it's worthwhile, but how do you pay for that? How do you make sure that if we make these obligations, we're not saying it to be popular and then turning around and saying, looks like we're not going to be able to do it. The idea was that we'll make it a pilot and we'll do that very thing. It's too expensive, we'll step this program down. 77,000 in the coverage gap. I've been told, when we talk about the coverage gap, do not assume that everyone within that coverage gap does not have access to health care, because many do. That number is smaller that we're talking in that gap. to expand, and this is getting really wonkish. My wife says that I just go into this legislative speak and I lose everyone, so bear with me. To expand, to hit this gap, the way the federal program works is you have to not only pay for the gap, but you have to go to 138% of federal poverty level. Well, those are people from 100 to 138 that the federal government's paying entirely for on the exchange them on their own, without a state portion. So to do that, you're going to cover 124,000 Utahns to look for and to arrive at the coverage gap or to provide health care for a number less than 77,000. Knowing that it's unknown, knowing that the actuarials could be wrong, we use the same actuarials, by the way. If someone says, well, Utah's just better at predicting, we're using a lot of the same actuarial firms to help us arrive at our numbers as the other states. And there's an intellectual thing, there's a moral dilemma or an intellectual dilemma that goes on here. It's very good if we want to see healthcare expanded to talk about the amount of people without health care and who need health care. I mean, Georgetown did a study that says that the number of children without health care right now is astronomical, and with Medicaid expansion, we'll be able to provide health care for those children. The problem with that, and I think that that would rise, catch the attention of everyone, where we want to make sure our kids are covered. The state of Utah does not have any cap on its health care that it will provide and ship for our kids. When we drill down on the numbers to say we're going to pay, there's an argument that this is very manageable. These numbers are not out of control. You can find the dollars to pay for this program as a state. But then there's the argument of there are all of these people, and these numbers don't match, by the way. If you look at these studies and when they talk about the people that you're leaving behind and this emotional appeal, those numbers do not match the wonkish numbers when we're trying to drill down and see how can a state project accurately and pay for its obligation. That matters because all you have in your lawmakers right now is how do we get it right. I'll tell you what happens when you get it wrong. These co-ops that were created through the Affordable Care Act, that are the one in Utah Arches that's now in state receivership. You have tens of thousands of Utahns who received a letter in October saying that health care would end. In the state of New York, the country's largest co-op, this just happening in real time, within weeks. Letters went out that their health care coverage would be discontinued with their co-op. That co-op in New York had a unique arrangement with one of the most renowned cancer hospitals in the country. They have 250 cancer patients who are losing their doctors and their hospitals because that co-op no longer exists. Now that was done under the banner of the best of intentions and helping people, which is important. But the fear that I have and many have is that you better be able to do what you say you're going to do. And where you see the federal government saying, we will pay all that risk corridor co-ops and insurance companies. The risk corridor is this. It isn't insurance anymore for the reasons of you're accepting pre-existing conditions and you're creating low premium rates. Well, that's a shared cost scenario now, not an insurance. It's not the math that Grant described where they won't cover you because the risk is too high and they say no. We're covering everyone. But you've got to do it through a shared cost scenario, which means you need a lot of healthy people to sign up so that you can pay for those that are sick. Well, ACA knew when they put this bill together that it wouldn't work like insurance because you do have the risk that you're assuming and paying for those that are very sick. So they had this risk corridor that the federal government said, we will pay all of it so that you can stay solvent, so that you can provide this care at a lower rate and that you can accept everyone. Well, Health and Human Services on October 1st sent out a letter. Again, we're just at the beginning of December here. October 1st, a letter went out and said, of that risk corridor, insurance companies and co-ops, we're paying 12% of that amount. I will tell you, try to live on 12% of the calories you're taking today. Try to take your business and take it 12% of the revenue your business would expect to receive. Nothing will survive on 12% of what was supposed to be funded fully by the federal government. And we think about those things, and we think about a 90% match that's more than that the federal government would fund for traditional Medicaid, which is for our permanently disabled and our kids. 90% match. Is that long-standing? can we bet on that? Can we tell the people's lives it'll impact? You can depend on our 10% because that 90% will be there. We have worries about that. We're looking, and this is what I want to get to in this panel, how are we going to move forward with Utah's solution? How are we going to do this where we can mitigate some of these risks that we think we're seeing in real time happen around this country? How can we get this right and provide the health care for those that need it, but do it in a way that we know is sustainable? And I want to talk about that because I think there are things that we can do and that we are doing to reach this vulnerable population. But that's the map, okay? In general terms, that's the kind of the map that we're worried about and that we're grappling with that makes this decision that much harder.
Real quick, I'd like to let Senator Shiwazawa talk on that. You sponsored one of the programs, essentially the Governor's Health in Utah program. Talk about the math and the finances from your perspective.
Let me just give you some numbers, and then you can compare these and adjust them as you will. We paid, since 2014, annually as a state, probably in excess of $700 million, somewhere in that neighborhood, in taxes from a number of different areas, whether it's Cadillac tax, Medicare taxes, or other taxes, medical device taxes. But that's going from the state of Utah back to the federal government. That tax is going to be every year as long as the ACA is in place. And no matter what Senator McConnell or Senator Hatch do, that is going to be in place at least for the foreseeable next couple of years. And so we have all that money going out of the state of Utah. Under the ACA, if we chose to do the expansion of Medicaid, whether it's Healthy Utah or a regular expansion of Medicaid, with certain waivers, we'd garner back to the state $400 to $500 million per year back to the state of Utah. And that's every year. And so in the period of time to which the speaker is alluding, there is truly going to be some state expense. And in 2021, we'll have, if you include the woodwork, probably $78 to $80 million of state expenditures. But at that time, we'll have drawn back into the state $400 to $500 or more millions of dollars each year to the state. Now that translates into 3,000 new jobs or more, based on some estimates. These are high-quality jobs coming to the state of Utah. And, oh, by the way, during this time, we're also providing health care for this group of patients who come to ERs and other clinics and don't have health insurance. And those costs, those numbers, are shifted to everybody else who pays their insurance. So people will look at the ACA and say, you know, Obama's to blame for double-digit premium increases. And to the extent that the ACA has taken away some of the safe harbors for insurance companies like pre-existing conditions or taking the cap off of lifetime benefits. And by the way, one of these times I'm going to talk about the PCA, which is Senator Hatch's bill that we've talked about, I've talked to him personally about, which would be his repeal and replace change for that. But those are some of the numbers. So if you want to know why that I and the Senate have been persuaded in going forth with the Medicaid expansion from a purely financial standpoint is, we pay this money to the federal government, they have not chosen to overturn this, and we could, if we embrace this program, bring back hundreds of millions of dollars every year to the state of Utah, and by the way, help thousands of Utahns, no matter what your number is in the coverage gap. Now you show me how it makes sense not to take that.
I actually want to make this because this is an important part of this math, okay? There was a premise when we were talking about Medicaid expansion about, and it's a strong one, and you just mentioned it, Senator, where we're paying our federal taxes for ACA. And we absolutely are entitled to the taxes that we pay as a state collectively to see those dollars arrive back here in the state of Utah. We do see those dollars in many forms come back, 100 to 400% of federal poverty level. Those exchanges are alive and well. Well, I don't know if they're well. Some of them, the co-op has gone, Arches has gone down, but they are receiving dollars. What we've been able to do recently is our fiscal analysts are not partisan. Some of these states in the country, the House will have, Republicans will have a fiscal analyst with their numbers, and the Democrats will have one, and the governor will have one. And there's like 4 or 5 budget numbers that states will compete in terms of what the real numbers are. one of the best practices in Utah is recognized for this is what we have a nonpartisan fiscal analyst. And these numbers for the fiscal notes for our bills or the budgets that we write, these are what we call consensus numbers, even with the executive branch, where we come down and we have consensus numbers in a bipartisan way. As ACA has rolled out and we have seen, instead of estimates, real tax dollars be able to track those dollars, it turns out that this year alone, we are seeing of all the taxes that we pay in ACA that we send to Washington, 20 million more that are already arriving here in the state of Utah, and that number is expected to be 100 million more by next year. So we see in the real tax accounting of this, or the collection of watching the revenue and seeing it coming back and accounting for it, we're already a state that receives more than what we're paying in those ACA taxes. It's no doubt that if you expand, you can make that number even higher. But the premise that we're not getting back the dollars that we're spending, I think that's at least minimally is arguable. I think no one's really challenged the fiscal analysts. I think they've been playing it straight. I mean, their numbers in terms of what they projected for the budget are as close as you'd ever hope your analysts could be, because we write these budgets 18 months ahead. So these are people that have been staring at this. And so I think that part is important for you to know. And I think it's good news that we're seeing those dollars right back in the state. So,
Grant, you've been wanting to weigh in?
Yeah, I have. I want to point out perhaps a couple of things to the speaker. You know, he's a budget guy, and that's his job. We've got to give him some credit. But I want to disagree with him on his math. I've had 11 years to be sick and have time to study on my hands. Now, I'm not a mathematician, but there's a couple of things that I think should be pointed out. First of all, the Affordable Care Act is called the Patient Protection and Affordable Care Act. One of its designs was actually to bring medical costs down so that we can afford to do more things. In other words, take less to get more. We've talked the whole morning about various what are called efficiencies, and it's a shame the speaker wasn't here. We've already had a discussion about risk corridors and why they were there and how they were designed and how politics eliminated them. And we've even began to discuss that there may be statistics out there that show that, yeah, I am expensive. People like me are going to cost a hell of a lot of money to fix. But once we're fixed and we're stabilized, then things begin to move forward. Now what begins to happen is you move more into what's called preventative care. Dr. Shiazawa will tell you this, that the most expensive way to treat someone is to ignore them first. The Affordable Care Act doesn't do that. It tries to get insurance in place. It even goes, and the Healthy Utah program goes a step further than that. It rather than just pure Medicaid expansion, it tries to bring some of these insurance pools into even some of these expensive, high-risk situations. It's exactly what Massachusetts did. It didn't do it with its Medicaid expansion population, and maybe it should have. Involving private enterprise in being more cost-effective is one of the ideas of the Affordable Care Act. It's actually a Republican idea. That's why I find it so ironic that in some ways it's being sabotaged. It's because I believe there's not the speaker, but I believe there's people out there that don't want the thing to work because they don't like that government will get involved in people's lives. Now that's a philosophical argument, not a mathematical. So what you have is you have, as our previous panelists pointed out, you have a lot of blame going on. You have the parties doing their thing, and they're going to do their thing. That's part of American politics. And then instead of sitting down, and I would agree with Speaker Hughes, a lot of these financial analyst numbers are correct, but what they're not taking into account is what would be called sabotage and circumvention. Now what happened with, because they wanted a political talking point, what happened with the risk corridors is they took away that risk management tool that was originally put in the Affordable Care Act before it should have been taken out. And that's why some of these co-ops are failing. And that's so we could have a political talking point about it. Now, I don't think the speaker even knows that. Now, he's a smart man, I know that. But the fact of the matter is, if that risk pool money would have been in place, Arches would not have failed. I talked with 2 doctors from Park City. They're mad too, because they had Arches. Now, mind you, part of the idea and the things that went on in Massachusetts was that insurance companies would jump in when perhaps they weren't healthy enough to do so. And so we could argue a long time about whether Arch's failure was a political situation or whether it was bad management.
On that note, I do want to get us back on course here, if I can.
Okay, great. I think the Affordable Care Act is going to make it. I do. And I think if we go forward, that's the premise we need to go forward on, to make this thing work, because people like, when we come back to the emotional issue, to ignore me is expensive. It really, truly is.
There definitely are, I mean, it's a very emotional issue, no doubt about that.
Sure.
I want to get back on track, though, and talking about how do we come together to close the gap in the state of Utah. A handful of plans have been introduced at different levels in the legislature, and none of them have come through yet. The most recent one was Utah Access Plus, and the majority of that was putting the burden that you talked about, Speaker Hughes, back to the hospitals, pharmacists, doctors, those that benefit from Medicaid expansion money. What have we learned so far from the plans that have been proposed that we can take and find common ground on and move forward for a plan in the state of Utah that the House could get behind?
So the key to getting something done in Utah is to do it the way Utah, I believe, has made its strides and separated itself from other states thus far. We have, on many fronts, some of the best practices in terms of how we put together our budget, or some of our transportation infrastructure planning, or we could go across the political spectrum or policy spectrum to point out how Utah enjoys one of the strongest economies in this country, and is looked upon by other states as having a way of looking at things and doing it in a successful way. I will tell you that I am aware of some of the circumstances surrounding the risk corridor and its politics. Rubio's amendment that made the risk corridor hard or impossible to manage. I'm aware of that. But what you need to know is that we never said that DC politics, we always recognize that DC politics could interrupt what we want to do in the state to deliver health care. We've never attached that to one party or the other. We have worried, and I think it's been borne out by the politics in the risk corridor, that that is the environment of the Beltway. And that is one that is very difficult for a state that enjoys a lot of the successes that we do to tether with the kind of politics that we're seeing happen in regards to health care. So I think that makes the case, and that makes our case. What we can do, Glenn, is we have to go back and look at some of these vulnerable populations. And we have to find where the state is spending money. And we've heard this, and it's been spoken about in this panel. Where are we spending dollars right now that we can redirect and spend in a wiser way, in a way that makes more sense? Remember, this was an $80 million general fund obligation. You need to know that the fiscal analysts have come back and said of the collections we expect in our general fund this year, we're 16 million shy. Our projections of general fund this year, you'll hear words about surplus in the budget this year. That's in our state income tax, which is dedicated to public education. In our general fund, we're looking at flat numbers right now. We're looking at about a $60 million general fund surplus. Traditional Medicaid's growth right now is $39 million of that $60 million, and we have not touched any other area of state government yet. We have a proposal that will be coming to help the homeless, where we want to take populations that are in one place and take mothers and children and put them in another location and separate some of these populations out. That's a $20 million request of one-time money and $7 million ongoing. Justice reform is looking at taking people that are sick, mental health issues where they found themselves physically addicted and going to jail. And justice reform that we passed last year would look to bring rehabilitation and mental health care to those that are addicted and not send them necessarily to prison, a graduate school of criminality for some. And that came with a fiscal note. And those are costs that can help us drill down into some of our most vulnerable populations. What I'm trying to say is, we as your lawmakers are going to be confronted with an array of incredibly important funding priorities. And every one of them, if you were sitting here, would say, I want to do all of them. It doesn't happen most of the time that you're saying, these are the dumb ideas, and these are the very important ones, and we're going to fund those, and we're going to call it a day. The worst thing that happens in any of these sub-appropriations committee meetings or when we draft this budget is we've walked away from incredibly important funding priorities. Even in Health and Human Services, beyond this issue, the House Chair of Health and Human Services will tell you there's $80 million a year of requests that are never funded, that are, if you were to see what those requests were, you would absolutely know that if we could fund those, we would be improving the human condition. And so that's the dilemma that we're in. We are looking at a year where the general fund money is very low. And if we had that $80 million a year obligation, it would be very difficult and we would find greater challenges more broadly. We've got to find those dollars that we are spending today and make sure that we're spending them the right way. I think the justice reform and the commitment and the increased funding for mental health is critical. And I think it touches this population. When we talk about the homeless, when we talk about how we can help this turn a trajectory and get people back on their feet, this will involve and this will touch and we'll be able to provide care if we can do this, members of this population. And we're going to have to take it, I believe, in those measurable and quantifiable steps, ones that we can budget, ones that we know, that we can test the next budget year. That is what I think is coming to the legislature in this session this year in terms of matching the dollars available with the will to get it right and do right by our constituents.
Senator Shivazawa, where do you see common ground moving forward? I would like to point out also, in addition to what you just said, Speaker Hughes, you and President Niederhauser have both said this issue, Medicaid expansion, is not going away. So it's something that is going to have to be dealt with. Senator Shivazawa?
Well, I'm glad to hear the Speaker recommit to the need to find a solution to the Medicaid expansion.
Did you hear that? You just made it a whole new definition. Did you hear that? Yes.
Let me just say three things in response to the importance for funding. Now, I chair one of the sub-appropriations committees, in fact, Business, Economic Development, and Labor. One of our tasks is to look at how the state can fund and incentivize businesses here in the state of Utah. Now, we do that with post-performance tax credits and different things like that, but it's based on faith. Faith that these businesses will continue to produce jobs and revenues to the state of Utah. And so we do that with the notion that these things are important for our, not only for our day-to-day structures and function and infrastructure, but also for jobs for our children and in the future. It's very important that the Speaker acknowledges, and I agree with him entirely, on mental health, judicial reform, substance abuse. One of the nice things about the Medicaid expansion was that this would give us funding to take savings that we're already using at the state and the county and city levels to help fund these people. And frankly, if you look at the three things that are so important for in the judicial system and prison reform, what is it? Public safety, accountability, and what's the third one? It's rehabilitation of the prisoners. Well, we do pretty good on public safety. We certainly have people in prisons doing the accountability aspect. But the third thing we're not so good at is rehabilitation. The Medicaid would bring us not only savings, but an opportunity to take these people who keep coming out of prisons with substance abuse, mental health problems, and lower recidivism, and improve the quality not only of their lives, but also improve our society in general. The second thing is, when you talk about $80 million, the Speaker's absolutely right. When we look at that in 2021, we've looked at that many times together and separately. Hospitals are willing, they recognize how important this is. The hospitals are willing to contribute up to $25 million, $30 million a year annually to help contribute to that. Now, if you take those savings from the hospitals alone, and when you take over 5 years, you look at $125 million. That's no small amount of money. And if you annualize out those costs on the Medicaid expansion, that would come pretty close in and of itself to doing a lot of that funding. Now, that's not taking in an unusual bump in enrollment, but that is also not taking into account those revenues that we would have that come from almost $500 million in new state revenues that come to the state. And so those are also figures. Now, they might be figures that say, well, we don't have a definite handle on those sorts of things, but there's undeniably some monies that are going to come back to the state of Utah by embracing this program, bringing those millions of dollars back to the state. So those are some of the things that, in terms of responsibility and keeping the numbers right, I think we all share together in our concerns. We are the best managed state. We're proud of that. We try to keep a balanced budget, And we want to balance the needs of education and other healthcare needs, but also do any expansion that we have here responsibly.
So if I could just add on that, as someone who has presented a bill on this, Senator Shibuzawa, what do you see as common ground with House members, because you're also very aware of their concerns? What type of a bill can be put together, or a plan can be put together that can be passed in the House?
Well, let me just say one thing. I just want to highlight to you some of the salient points of Orrin Hatch's bill, the Patient Care Act. Now, I don't know how many are familiar with that, but let me just give you 4 or 5 points off there. One thing he would preserve is no lifetime limits on the insurance benefits. Another is he would preserve the young adult stage 26. Another is no pre-existing conditions. Have you heard of that before? And then the other thing would be to fund low and middle income families and patients with tax credits. And the 5th thing would be to offer patients on Medicaid commercial insurance. You know what that sounds like? That sounds like Healthy Utah on a national basis. This is Senator Hatch's prescription for repeal and replace on a national basis. So if there can be common ground, what I would say to the House, and let's just be pragmatic here. We know where the Senate can go and where some of the Senate sentiments are in terms of expansion into finances. For 2 years, we've gotten either a partial expansion or a full expansion bill in the form of Healthy Utah through the Senate. We recognize in the Senate that basically anything that comes forth has got to go through the House, as it should. And it has to have the agreement and the concurrence of the members of the House of Representatives. So basically, ladies and gentlemen, it's what the House will agree to at this point. And
So what will the House agree to, Speaker?
So, thank you. The governor's office wants to keep homeowners. Here's the thing. The plan that we came together with, this Gang of Six, trying to find a way forward, it's received its criticism that we met and we tried to do this. But I will tell you this. It was incredibly disappointing to me as we had discussed some of the things we're talking about here today about this uncertainty in terms of the dollar amounts. Remember this, when we talk about 90% match and the state putting in $1, know that if the state were to put $1 in to get $9 more for Medicaid expansion, that those $9 don't arrive in state coffers, they go to the healthcare providers who provide the care. So your hospitals, your physicians, pharma, others. And so the idea that we worked on in the interim after the session that I thought was reasonable was as we discussed during the session some of this uncertainty that we were worried about, whether the feds would keep their commitments and actually fund this to the rate that they said they would. With the amounts that we're estimating, because we don't get to pick an amount of dollars, we don't get the budget to a dollar amount, we have to do it to a percentage, and the uncertainty with that. With those arguments or those concerns that we were expressing were being rejected, and being rejected by the healthcare community and healthcare providers wholly. So the plan that we put forward really was to say this to the hospitals, to the doctors, physicians, pharma. If you stand to leverage $1 for $9 more, if you believe that the federal government will satisfy its portion, if you think this is real, we want to create an assessment and enable and empower healthcare providers to take us. And for physicians, it was $67 a month. Okay? The hospitals even came and said they opposed a plan of this nature where there was this assessment because they wanted a cap. They wanted budget certainty. They wanted to know how much a year they were going to pay. Does that sound familiar? They wanted to know what that dollar amount would be. We had gone together to Secretary Burwell of Health and Human Services, and we said, Secretary Burwell, check our math. Check the actuarial. Make sure we're not gaming it. But if you believe that this actuarial is genuine, that it's real, that it's based on real math, let us budget to that number. That budget certainty will take so much of this concern and put it to bed. And if it only at the end of the day funded 98% of the program, 95% of the program, let us do that at least. And it was Health and Human Services and Secretary Burwell, who I like her. I think she's a great lady. She's got an impossible job. She said, no, They would not do that. When we looked at the assessment for physicians, understanding that all hospitals accept everyone, but physicians don't necessarily. And we said, look, how about, could we, because we're going broadly, to try and find the dollars to leverage and be able to deliver Medicaid expansion, can we just assess those physicians who accept the Medicaid expansion patient? And the answer to that was no. And so we assessed it broadly, and we had many physicians that were very angry that we would look to assess any amount of money for this program. I did not believe that the assessments were prohibitive. I expected the media and others to look at those numbers. Certainly the same media that was criticizing or worried that the state wouldn't fund it, to look at these assessments and the dollars they were, because I don't believe that they were deal breakers, and really bring it to the public awareness of what we were talking about. I don't think that happened.
So are there any other ideas?
So I still like that. So my point is, I think that assessment model works. I think it would be good. I think what you're going to find, since we've heard...
So it's not dead then?
Well, no, this is it. I think we've heard uniformly amongst all healthcare providers that if you're not going to cap it, if you're not going to limit it, and physicians really don't want any part of it, then they're not going to participate. But I do believe that with hospitals, there is a capped amount that they would like to contribute towards providing greater access to this coverage gap. And I think we have to look at that and appreciate that and work with our hospitals that want to provide that amount. But remember, they're coming in and their rules are, we want to cap the amount. So I think the model that we'll look at is one where we look for budget certainty. We're going to look for the dollars that we know are coming, that we can provide the services that we know are critical, but know that we can keep our promises. This is not going to be a pilot that come back to us in 2 years and see if we still want to do it or not. We've seen smaller areas of our demographics. When we've pulled, because of shortfall years, our dental care for Medicaid recipients, it's not something that you should do to people. I don't believe yo-yoing benefits back and forth improves the human condition on the long view. I think it's important that this state know what we're getting into and commit to our constituents. We're in this, and we're in this for the long haul. And you have to have a plan that you know will do that. The hospitals are saying back to us, we want it capped. I understand that. I share that concern as well. So I think you'll have a measured approach. I think it will be one that we know what the dollar amounts are. It won't be to a percentage. And I don't think it's one that we tether with the federal government. I think it's very generous. It's all the money now. But I think you can see a lot of the problems in the politics that are going on in that town. But I don't know that we want to put Utah's health care in the hands of politics that are happening there. Whatever administration wins the next election, or whatever Congress looks like, I don't think that's a place that we should be depending on our plan.
All right, we only have a couple minutes left. I want to get back to Nate real quick. Talk from your perspective and your analysis, what type of plan makes the most financial sense for the state of Utah?
Interesting question. First, I guess I should note that the Governor's Office of Management and Budget, unfortunately, is not in consensus with the Legislative Fiscal Analyst Office around how much Utahns are paying in federal taxes and getting back under the ACA. I wish we were, because that makes my job as an analyst a lot easier. Our analysis uses that same sort of foundational report by the National Congressional Budget Office, which was entitled The Budgetary and Economic Effects of Repealing the Affordable Care Act, and shared down some of that data to Utah and showed something around, on average over the next 10-year period, Utahns will be paying $500 million more in federal taxes than what we'll be receiving back but for the Affordable Care Act. Some of that has to do with reductions in Medicare and Medicare rate increases in Medicare reimbursements, of which the Legislative Fiscal Analyst Office dichotomized from the broader analysis. And so, not to get too wonky, but we still have some work to do to kind of come to consensus around those numbers there. In terms of what makes sense in an expansionary Medicaid environment, I think the same dilemma that was so well articulated by the speaker and around the 90-10 match and 70-30 match. It's very much more expensive to cover the subpopulation of the expansion population that you're most interested in covering, and it's those in the coverage gap and those that have the most acute needs in the coverage gap. Not more expensive, not necessarily more expensive in aggregate, but more expensive per capita. And so that's the trade-off that's been debated and been faced with. And I won't go over all those same information points, but
to save a little time for question and answer, but thank you so much for being here, all four of you today. And as you can see, a lot of different ideas and just how complex this issue is, and I can guarantee you guys it's something I'll continue to be following as the session approaches.
I have the mic.
I'll yield.
We've all heard the blame the doctors argument since Utah Access Plus. As a pediatrician retired, we never made overhead why our reimbursement for Medicaid. We have no hope that we would. That aside, I didn't hear you say what you thought might work. Could you do so? Sir.
So what we do is we would look for those that would want to participate. So the healthcare providers that have stepped forward, frankly, are the hospitals. They're looking at a fixed number a year, and we would try to reverse engineer from the revenue that we have. Now, just know this, the state isn't trying to just shift all the costs. As I mentioned earlier, we as a state took the cap off of CHIP for children years ago. We assume all the health care for within the range of household income for children, and we continue to do that. Part of that $80 million of ongoing Medicaid expansion was what we call the woodwork effect, where if adults had an ability to sign up for health care, they would at a greater frequency sign up their children for health care. And so some of that increase in cost wasn't from a new program per se, but from those that already qualified, the children, being now covered where they weren't before. And so we call that the woodwork effect. But in every scenario that we've looked at, we want to make sure the state of Utah, and that number was in excess of $30 million a year, that we would be covering the part for these children that would be getting the health care they needed that they didn't have before. For the other portions, the models that we've used are to look at what the dollars that we would have that would come in and how we could deliver them. We would look at that 70-30 traditional Medicaid match. It's theoretically getting less than you would with 90, but I have a hard time believing that Congress will interrupt its traditional flow of Medicaid funding as I do the 90%. 90% being a lot. Just take George W. Bush's No Child Left Behind. And after that administration left, ask any Republican or Democrat what they think of No Child Left Behind. Once that president's banner legislation, that president's gone. Our fear is that 90 could see itself blended down very quickly. And in fact, even President Obama's proposed budgets had already begun to contemplate blending the 90% match with the traditional Medicaid match. So we think for certainty, we would pay 30% for the certainty of 70% match under the traditional Medicaid program. So we would look at that, we'd look at a traditional Medicaid approach, we would look at the dollars that the care providers would contribute to this, and it makes all the sense in the world why the hospitals would be either providing the charitable care, they're providing some of this critical care already. We want to see those dollars and leverage those dollars. So that would be the plan. You'll find though that those numbers that you can afford versus the projection of 90% would be the more frail, or I hate to use the word frail, the more vulnerable or the most vulnerable amongst us. That would be our first step, or the one that we would prioritize the highest, or those that are most vulnerable. So, I don't know, we're talking conceptually, but that's a little bit more meat to the bones.
So I would can I make one response to Dr. Metcalf's comments? And let me just tell you for the sake of transparency, the speaker knows this. I frankly, advising personally, I really dislike the notion of physician-provider tax on this. You heard that from me repeatedly.
I did.
Now, having said that, though, there are great benefits that would come both to the provider community in general from the Medicaid expansion. But let's look at the general population. If you look at every state that's embraced the Medicaid expansion, take Arkansas, for example. We've talked to Arkansas, 22% uninsured, now they're about 11% uninsured or uncompensated care. When their governor ran, one of his premier campaign promises was to repeal Obamacare and the expansion. They've just re-upped that for 2 more years. They can't step away from the economic benefit that has done for that particular state. Whether you like that notion or not of federal dollars, there's going to be some real economic benefits that come to the state of Utah that will benefit the provider community, the hospital community, And it stands, and the hospitals will benefit from the uncompensated care. Another thing that we talked about extensively, and I know ad nauseum with the speaker. But in terms of an ideal plan, the first plan Tom and I did was the partial expansion. In other words, a full coverage gap. And I'd certainly settle for that. If that's the way we go, it would be cleaner and simpler. But we can't get that with the enhanced, that's the problem. We can't get the enhanced match. But even at 70-30, that might be a very doable item. But we'd still have to get buy-ins from the hospitals and look at the numbers, because there may have to be some contribution from general fund. We don't know yet, because that's going to look at the revenues. Thank you.
So just a couple things. One is my concern is that the solutions currently being spoken about, and you're starting to evolve more towards where I think the right solution is, has been an either or. So the responsibility is either going to be on the provider community to ante up their share, or it's going to be on the government side to take the responsibility. And I have not heard a hybrid approach in which we all share in the responsibility of taking care of our people. So that's the first observation. The second observation is I was in a political appointed position many years ago. 9/11 hit, and this is to address your concerns about decisions under states of uncertainty. 9/11 hit, we thought we were certain until 9/11, and then 9/11 hit and revenues went down the tubes. I was in a political position at that time, and I watched the legislature, against my emotional side, take the responsibility to make 3 rounds of budget cuts in an 18-month period in order to balance the budget. And on an emotional level, it was very difficult to do because I was the one that was making decisions about laying people off and cutting here and cutting there to meet the requirements of the legislature. But as I grew through that experience and watched what happened, that we made it through that trial and tribulation, the economy stabilized, and we were able to move back up and proceed as we had before. So I learned through the wisdom of that experience the benefits of following those principles. So I understand the concern that you have about making decisions under states of uncertainty. But I also recognize that the legislature has the mechanism in place to make course corrections when needed. And so I'm a little bit concerned about the fact that you're trying to design a plan that's going to be perfect and solve these problems and assure everybody that there's going to be no problems in the future, and I think that's unrealistic. I think that we need to share in the responsibility of solving this problem, and we need to recognize that the first solution that we test may need to be tweaked and need to be changed over the course of time as we learn more about it. Thank you.
I appreciate that observation, and I just want to emphasize that even these plans that we're talking about that are a little bit, that are scaled smaller, we're looking at the federal participation that would be at a traditional match and not the higher match. Let me just give you a scenario. If this scaled and smaller plan, in and of itself is not perfect, because it would still require the state to contribute $35 million a year in general fund money. If we only have $60 million in surplus in general fund today in the state of Utah, or projected, and $39 million of that in traditional Medicaid increases are there, there's not even the $35 million for this scaled back plan that we're talking about for the general fund. And that doesn't talk about the public employees' compensation. There's a myriad of items that really depend on that general fund. And even as we talk a smaller, more measurable plan, its pressure on that general fund will be great. So I feel that even as you're describing that, that is still a risk. That is not a perfect plan, and that is not immune. We are not taking the state and creating some immunity from the economy or its budget challenges. There is a significant state role in that portion, and still a federal role. And so it's still a big number. You just need to know that. That's a big number. And if you look at other areas of public policy, and I keep going back to our homeless situation. It's in Salt Lake City, but it's a state issue. And there is an incredible amount of work that's been done over the last year to bring disparate organizations or sides or opinions together for a game plan. And it'll be a tragedy if that plan is never successful, because the state is unable to participate in that. And that comes at a dollar amount as well. So we are mindful of that, and that is one of the things that we've got to get right. I will tell you again, it would be the easiest thing for me to do, to sign up for this plan, because whether it's Secretary Burwell in Washington, D.C. right now, or myself that you're looking at right now, when the bill comes due to this state, I won't be here. I don't have to worry. This won't be my problem. I could enjoy a ticker tape parade right now, having done this, worrying or not worrying about what those consequences would be later. But we look at a long view, we look at the commitments we make, and we don't want to be necessarily set up for failure. It's never going to be perfect. Those budgets are 18 months in forecast, so we're inherently taking some risks when we do that. But to your, that's a long way of saying I appreciate those points and agree. It won't be perfect, and we've got to make sure that we can get through those hard times. And I think Utah does. I agree.
Right, on that note, we're out of time. Thank you very much.
Sorry.
Oh, we have one.
There's one more question from this side of the room. So this is the last question.
Thank you, Ryan. I just had a question, because you were talking about, I understand the budget constraints, but how to expand the budget. Just recently, we had Proposition 1 put to vote to the society, us, as I alluded to, that was projected to raise $108 million annually, and that was only from 17 of the 29 counties. So I'm guessing if it went statewide, there's even more, and that's 1/4%. And can't a solution like that be put to the Medicaid expansion, where you would have then more than probably, I don't know, 120 million if it went statewide in revenue raise? Is that a possibility?
You mean like a poll question or a Proposition 1?
Take it to the citizens of Utah, exactly.
You know, that came up, and I had a physicians-only town hall meeting, and I did the physicians only because of some of I just want to talk to physicians so they could, hang me in effigy and bring their pitchforks and torches and tell me.
You want us to hang you instead?
So I didn't want them to turn on each other when they could all just turn on me. But that was brought up in that meeting. How about a statewide ballot measure? Everybody pay a percentage of sales tax or some portion to cover that expansion. That has not been delved into deeply, but it's a concept that is certainly worth talking about.
Say a lot of, but put it to us. I think a big percentage of the state wants to see people have health coverage. My personal opinion, an educated society is a good, productive society, and a healthy and educated society is even more productive. Again, as Dr. Shiozawa alluded to, the economic benefit coming back to the state, if we can get people healthy, back to work, in some cases, I think we need to look at that. And, I am for one voting to pay 1/4%.
We've used, or to look at what the dollars that we would have, that would come in, and how we could deliver them. We would look at that 70-30 traditional Medicaid match. It's theoretically getting less than you would with 90, but I have a hard time believing that Congress will interrupt its traditional flow of Medicaid funding, as I do the 90%. 90% being a lot. Just take George W. Bush's No Child Left Behind. And after that administration left, ask any Republican or Democrat what they think of No Child Left Behind once that president's banner legislation, that president's gone. Our fear is that 90 could see itself blended down very quickly. And in fact, even President Obama's proposed budgets had already begun to contemplate blending the 90% match with the traditional Medicaid match. So we think for certainty we would pay 30% for the certainty of 70% match under traditional Medicaid programs. So we would look at that, we'd look at a traditional Medicaid approach, we would look at the dollars that the care providers would contribute to this, and it makes all the sense in the world why the hospitals would be either providing the charitable care, they're providing some of this critical care already. We want to see those dollars and leverage those dollars. So that would be the plan. You'll find though that those numbers that you can afford versus the projection of 90% would be the more frail, or I hate to use the word frail, the more vulnerable or the most vulnerable amongst us. That would be our first step, or the one that we would prioritize the highest, or those that are most vulnerable. So I don't know, we're talking conceptually, but that's a little bit more meat to the bones.
So I have a trend.
Can I make
Just
one
one second.
response to Dr. Metcalf's comments? And let me just tell you for the sake of transparency, the speaker knows this. I frankly, advising personally, I really dislike the notion of physician-provider tax on this. You heard that from me repeatedly.
I did.
Now, having said that, though, there are great benefits that would come both to the provider community in general from the Medicaid expansion. But let's look at the general population. If you look at every state that's embraced the Medicaid expansion, take Arkansas, for example. We've talked to Arkansas, 22% uninsured, now they're about 11% uninsured or uncompensated care. When their governor ran, one of his premier campaign promises was to repeal Obamacare and the expansion. They've just re-upped that for 2 more years. They can't step away from the economic benefit that has done for that particular state. Whether you like that notion or not of federal dollars, there's going to be some real economic benefits that come to the state of Utah that will benefit the provider community, the hospital community, and and the hospitals will benefit from the uncompensated care. Another thing that we talked about extensively, and I know ad nauseum with the speaker. But in terms of an ideal plan, the first plan Tom and I did was the partial expansion. In other words, a full coverage gap. And I'd certainly settle for that. If that's the way we go, it'd be cleaner and simpler. But we can't get that with the enhanced. That's the problem. We can't get the enhanced match. But even at 70-30, that might be a very doable item. But we'd still have to get buy-ins from the hospitals and look at the numbers, because there may have to be some contribution from general fund. We don't know yet, because that's going to look at the revenues. Thank you.
So just a couple things. One is my concern is that the solutions currently being spoken about, and you're starting to evolve more towards where I think the right solution is, has been an either or. So the responsibility is either going to be on the provider community to ante up their share, or it's going to be on the government side to take the responsibility. And I have not heard a hybrid approach in which we all share in the responsibility of taking care of our people. So that's the first observation. The second observation is I was in a political appointed position many years ago. 9/11 hit, and this is to address your concerns about decisions under states of uncertainty. 9/11 hit, we thought we were certain until 9/11, and then 9/11 hit and revenues went down the tubes. I was in a political position at that time, and I watched the legislature, against my emotional side, take the responsibility to make 3 rounds of budget cuts in an 18-month period in order to balance the budget. And on an emotional level, it was very difficult to do because I was the one that was making decisions about laying people off and cutting here and cutting there to meet the requirements of the legislature. But as I grew through that experience and watched what happened, that we made it through that trial and tribulation, the economy stabilized, and we were able to move back up and proceed as we had before. So I learned through the wisdom of that experience the benefits of following those principles. So I understand the concern that you have about making decisions under states of uncertainty. But I also recognize that the legislature has the mechanism in place to make course corrections when needed. And so I'm a little bit concerned about the fact that you're trying to design a plan that's going to be perfect and solve these problems and assure everybody that there's going to be no problems in the future, and I think that's unrealistic. I think that we need to share in the responsibility of solving this problem, and we need to recognize that the first solution that we test may need to be tweaked and need to be changed over the course of time as we learn more about it. Thank you.
I appreciate that observation, and I just want to emphasize that even these plans that we're talking about that are a little bit, that are scaled smaller, we're looking at the federal participation that would be at a traditional match and not the higher match. Let me just give you a scenario. If this scaled and smaller plan, it in and of itself is not perfect, because it would still require the state to contribute $35 million a year in general fund. If we only have $60 million in surplus in general fund today in the state of Utah, or projected, and $39 million of that in traditional Medicaid increase increases are there. There's not even the 35 million for this scale back plan that we're talking about for the general fund, and that doesn't talk about the public employees' compensation. There's a myriad of items that really depend on that general fund. And even as we talk a smaller, more measurable plan, its pressure on that general fund will be great. So I feel that even as you're describing that, that is still a risk. That is not a perfect plan, and that is not immunity. We are not taking the state and creating some immunity from the economy or its budget challenges. There is a significant state role in that portion, and still a federal role. And so it's still a big number. You just need to know that it's a big number. And if you look at other areas of public policy, and I keep going back to our homeless situation. It's in Salt Lake City, but it's a state issue. And there is an incredible amount of work that's been done over the last year to bring disparate organizations or sides or opinions together for a game plan. And it'll be a tragedy if that plan is never successful because the state is unable to participate in that. And that comes at a dollar amount as well. So we are mindful of that, and that is one of the things that we've got to get right. I will tell you again, it would be the easiest thing for me to do, to sign up for this plan, because whether it's Secretary Burwell in Washington, D.C. right now, or myself that you're looking at right now, when the bill comes due to this state, I won't be here. I don't have to worry. This won't be my problem. I could enjoy a ticker tape parade right now, having done this, worrying or not worrying about what those consequences would be later. But we look at a long view. We look at the commitments we make, and we don't want to be necessarily set up for failure. It's never going to be perfect. Those budgets are 18 months in forecast, so we're inherently taking some risks when we do that. But that's a long way of saying I appreciate those points and agree. It won't be perfect, and we've got to make sure that we can get through those hard times. And I think Utah does. I agree.
Right, on that note, we're out of time. Thank you very much.
Sorry.
Oh, we do have one.
There's one more question from this side of the room. So we're good, this is the last question.
Thank you, Riley. I just had a question, because you were talking about, I understand the budget constraints, but how to expand the budget. Just recently, we had Proposition 1 put to vote to the society, us, as I alluded to, that was projected to raise $108 million annually, and that was only from 17 of the 29 counties. So I'm guessing if it went statewide, there's even more, and that's 1/4%. I mean, can't a solution like that be put to the Medicaid expansion, where you would have then more than probably, I don't know, 120 million if it went statewide in revenue raise? Is that a possibility?
You mean like a poll question or a Proposition 1?
Take it to the citizens of Utah, exactly.
You know, that came up, and I had a physicians-only town hall meeting, and I did the physicians only because of some of I just want to talk to physicians so they could, hang me in effigy and bring their pitchforks and torches and tell me.
You want us to hang you instead?
So I didn't want them to turn on each other when they could all just turn on me. But that was brought up in that meeting. How about a statewide ballot measure? Everybody pay a percentage of sales tax or some portion to cover that expansion. That has not been delved into deeply, but it's a concept that is certainly worth talking about.
Say lotto. But, put it to us. I mean, I think a big percentage of the state wants to see people have health coverage. My personal opinion, an educated society is a good, productive society, and a healthy and educated society is even more productive. Again, as Dr. Shiozawa alluded to, the economic benefit coming back to the state, if we can get people healthy, back to work, in some cases, I think we need to look at that. And, I am for one willing to pay 1/4% increase in sales tax to have people have health.
Okay, thank you so much, Glenn and the panel. Thank you for all being here. Excellent panel, well done. We have a 5-minute break instead of a 10-minute break because we did go a little long, but it was an important conversation. So please come back.